Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello, everyone, and welcome to this episode of the Doc Podcast. I want to start by saying that I am beyond excited for today's show. As a Doc Podcast officially turns 1 year old, we welcome an absolute legend in the world of orthodontics, Dr. Tom Pitts, as today's guest. Dr. Pitts earned his dental degree from the University of Pacific and completed his orthodontic residency at the University of Washington. He's an Army veteran who has practiced orthodontics since 1970 in Reno, Nevada, and is the author of multiple publications since that time. He's been lecturing nationally and internationally since the mid-'80s with an emphasis on teaching orthodontic finishing and smile arc protection. Dr. Pitts is currently an associate clinical professor in the orthodontic department at Rosemont University and has served as the executive clinical director of Ortho Classic since 2014. He's also the founder of the Pitts Progressive Study Club and is widely known for his Pitts protocols, which focus on achieving superior smile aesthetics and occlusion while simplifying mechanics and decreasing total treatment time. Dr. Pitts is truly an amazing orthodontist and educator, and beyond that, a remarkable human being. And I'm really looking forward to spending some time with him today. So with that, I would like to extend a sincere welcome to Dr. Tom Pitts. Welcome to the Doc Podcast, Tom.
Thanks so much, Mike. It's really an honor to be here with you. You're a great speaker and a teacher, and I love your podcast.
Thank you so much. It means a lot to me, and I really do feel blessed to do this a year in, and it's been so much fun, and it brings me to be able to talk to people like yourself who just have done so much for this field, and I learn myself every time I talk to somebody, and just really enjoying it and getting to share this content with others. And one of the most gratifying things, and literally probably 15 minutes before we started ours, I got an email from somebody who practices in New York City saying, he really enjoys this content and it's helped him see things in a certain way. And that's why I do it. So I know that from today's episode, people are going to have a really cool insight into the profession in a unique way that they may not have had. You're known, many of the older orthodontists know of you or know you personally. Many of the younger ones have heard your name, but you're extremely humble, and you probably don't want me to say this, but you are a true legend in the world of orthodontics. You have done so much in your time. You've been in practice almost 55 years. You were trained by and worked with people like Dugoni and Ricketts and Roth and Hickson and Dawson and Damon. And I mean, these are people that most of us have just heard of. Maybe we heard speak somewhere if we were fortunate enough for that, but you were hand in hand with them and in some of their earlier classes and been learning from them and using what you learned from them throughout your career. And you're one of the few people, and I'm not just saying this, that you just don't hear a negative word about. In fact, conversely, everybody, when I was leading in and some people knew you're on the show, they're like, you're having Dr. Pitts. I mean, people just rave about you as a human and just what you've done for so many other people because of your passion for education. So we'll talk a little bit more about that today. And like I said, you probably didn't want me to say that because of knowing who you are, but I just felt it was very important to recognize you for all that you've done for this profession. And truly thank you for all that you've done for us for so many decades.
Well, thank you, Mike. You may not know some of the people that may not speak that highly of me, but that's very complimentary.
Well, it's a credit because I know as myself as someone who's pushed the limit and pushed the envelope of the profession in a lot of ways, even what I'm doing now, it's not always received well. And I don't shy away from that, but I know there's some people who don't share my beliefs on a lot of what I do and what I teach and how I approach it. And anyone who does that is going to have a fair amount of naysayers out there. But even people who may not agree with the way you approach things all have tremendous respect for who you are and the way you approach and what you've done for this profession. So just thought I'd share that with you because, sometimes when you're in the fight doing it, you may not realize that side, but it's sincere and true. So with that, just give everyone a little bit of a background about you really have a storied career in orthodontics. And it's been an evolution in terms of where you started and where you are today in your approach to patient care. So just kind of go through that if you would, and just tell the audience a little bit more about where you started and how you got to the point you're at today.
Well, it's a good question. I could go on for a long time about the history of how I've done certain things and how I got into orthodontics. I was originally going to be a prosthodontist when I was in dental school. Art Dugoni came back. He was a pediatric dentist for 13 years, and he got tired of all these extraction slips coming through
Mm.
for his patients. And so he went to University of Washington, and when he got out the first year, he came to UOP to teach. And I was a senior at the time, and he taught undergrad ortho.
Okay.
And he's the one that really got me interested in ortho. And then I started going to his office. And of course, he was really into early treatment
Mm. Yeah.
because that was his passion
Yeah.
with the kids. And so that's how I started in orthodontics. And once I got into school, it was a very traditional school, and a lot of extractions,
Mm.
a lot of stability issues, and Charlie Tweed's philosophy. And so I really started to think more non-extraction as I went through the program and worked on patients.
Mm.
And so when I got out, of course, early treatment was very, very important to me because I wanted to do as much non-extraction as possible, and I could do more non-extraction at that time by starting early.
Mhm.
And then I was fortunate to attend Dr. Ricketts'
Mm.
continuum
Mhm.
in 1974. And when Dugoni would do his early treatment, it was mainly lingual arch, holding the E space, using a neck strap headgear if he needed it,
Mhm.
and doing some expansion of the upper with expanders and maybe an upper 2x4, that type of a thing.
Mhm.
When I went to Ricketts, he was really into comprehensive early treatment.
Mhm.
And he was really concerned about the faces. And so then I started to get more comprehensive and started to do more 2x4s. And he was the first person I saw expanding arch wires. That was a no-no at the University of Washington.
Yep.
And so he didn't use a rapid paddle expander. He used a quad helix
Mhm.
soft expansion. So it really opened my eyes to a new form. And he had cases that were 20, 30 years out of treatment, and showing just beautiful cases
Mhm.
that were still some nighttime retainers, but they were beautiful. So anyway, that's where I started worrying about facial aesthetics. And so then as I got into that, as far as early treatment was concerned, I wanted to not only widen the arches and create extra space so that I could have the teeth erupt in the center of the alveolus. And
Mhm.
so it really helped. I started bonding up some primaries so I could put some coil springs in so I could I made an extra 2 millimeters of space on each side for the lower cuspids,
Mhm.
and the same on the upper cuspids. And so then with the widening and then the retention, impacted canine started uprighting and
Yep.
coming into the alveolus, and so that's when I started bonding up the primary teeth. And then I got into passive self-ligation. I started in about 1980 something. A company came out with I forget the name of the bracket, but it was a passive bracket, and
Mhm.
I started to see that I could widen more uh, early. I didn't get as much lower proclination when I would widen early if they were crowded. And so that combined with my early treatment stuff. And then what I started doing is I started putting tubes. There were little Inconel rectangular tubes on the primaries. But then that was an issue because when I get to the 1425, it was hard to feed them through all of the
Right,
tubes.
right, yeah.
And so then we went to eyelets because I had the passive front brackets anyway. And so then I could feed them through, and I could use the coil spring between the eyelets to make extra space. So that's kind of my early treatment. I really started working on smile aesthetics back in the 90s, and mainly with the permanent dentition, but I was also doing mixed dentition work. So I was working on incisal display and smile arc and that sort of thing. And so I just kept working. I have a slide that says, imagination is more important than knowledge. And that's a quote from Einstein. And it's so true. We all have so much knowledge, just like we were talking about the instructors today that are teaching traditional orthodontics that they learned, and it goes back to the 60s.
Yep.
But we all have knowledge, but to imagine and to then try to envision and then set up, and then of course it's not just that, but then you have to evaluate how effective your little tricks are. So
yep.
That's and I think that's one characteristic that you have. I wanted to say it was Bruce Ollins that told me. He got on the phone and he says, "I want you to go to YouTube and listen to Mike DeLuke." I think it was number 3. And that was really so refreshing, because they've done all of the studies on Airway using rapid palatal expansion early. But I was able to see that my Airway was so much better just by doing what I was doing, not using rapid palatal expansions. So when I saw your presentation, I just about flipped out, because then you did the CBCT studies and the volumetric. And that was really refreshing, Mike. And that's one of the reasons why I got a hold of you, because I was so excited. And so I'm so glad that you're out doing what you're doing. And you are keeping your fingers in it by teaching at the university, but I'm still seeing patients.
That's amazing.
Not very many, but I could keep my hands in it so I can play with my imagination and see. And then I had to come up with ways, if I was going to do that, if I was taking a deep bite, instead of intruding upper anteriors and lower anteriors, then I had to figure a way that I could take a deep bite, correct it, and extrude it anteriors and still come up with a beautiful bite. So it's been very exciting to me as far as innovating those little things. And that's I'm not here just to give back to the profession. I'm here to help the kids that are being treated by these orthodontists all over the world. And so
that's my passion too.
I got that. And so then, of course, I was being criticized for my bracket position, but it's not just bracket position. It's how I disarticulate teeth and where I extrude and intrude. And it just turns out it's really a discipline that it's kind of not intuitive. And so that's what it takes. Not only passion for that beautiful aesthetics and of course the Airway and the occlusion, but it also takes skill. I mean, it has to be taught, because it's not taught.
Why do you think that is? Why do you think it's still? Because I had multiple guests on the podcast that we kind of rack our brains on this, and I think about this often, and I have certain theories, but I'd love to hear your thoughts as to why. I mean, you just said Dugoni understood this, presumably based on the time frame you were giving, in the 60s into the early 70s, and then Ricketts clearly in the mid 70s was huge in this arena. And we've had all sorts of art. Bell published a lot on it in the early 80s, and AJO on the benefits of early treatment. And McNamara has done a ton with Frankie and Bichetti on the benefits of this and expanding lower arches. And again, we could go back and forth on the way to do it, but the concept of early treatment. But yet we still have this profession that's teaching that expanding and developing arches in a patient without a posterior crossbite is like sacrilegious. And I for the life of me, I can't understand why. I want to take a moment to thank the sponsor of today's episode, Retainers for Life. We all know how stressful in-house retainer fabrication and replacement can be, especially during those busy summer months. And that's why you need to check out Retainers for Life. Retainers for Life is an affordable and convenient retainer replacement program that not only fabricates custom retainers for your patients, but they actually deliver the new retainers directly to your patient's doorstep. And the best part is that you, the doctor, get to maintain control over the retainer design and material, set your own fees, and generate additional revenue for your practice. Plus, as a very satisfied customer of Retainers for Life, I can honestly say that the entire team is truly amazing and will be there to assist you and your team from onboarding to implementation. So go to afterorthorevenue.com and schedule to book a discovery call now with a Retainers for Life team member. And be sure to use my exclusive discount code DOC2024 to get $2,500 off your enrollment fee. Again, that's afterorthorevenue.com. Use my exclusive discount code DOC2024 to get $2,500 off your enrollment fee. Trust me, you won't be disappointed.
Well, it's just a holdover, and the teachers in the universities only teach what they were taught. They haven't moved on, and so they don't know how to do it. So if what we're doing is right, that makes what they're teaching is wrong, and so they can't accept that.
Yeah, it's
and
hard to
so
accept.
When I was at UOP, I'm no longer there, by the way.
Okay.
And I moved to University of Las Vegas, Nevada, Las Vegas, and what their program, there's a pediatric dentistry residency, and they do all the early treatment.
The pedos, yeah.
The pedos. And so now
Wow.
I'm no longer at UNLV, actually. I'm at Roseman in Las Vegas area. They had not been taught much early treatment until now. We're just getting into that at Roseman. So there's not many universities that really get into early treatment, and then they've been taught not to expand arch wires. Just
oh my gosh, completely. Yeah. And I hear so much about slow expansion, this slow expansion, rapid expansion debate. And because you're not blowing the suture open, you're not getting orthopedic change. I mean, there are plenty of studies, and the literature is full of studies showing that you get orthopedic change. Again, younger, the key is patient age and getting these patients young and helping to develop the bone. And that, yes, you're going to get some dental tipping, but same with RPE. I mean, RPE is at best 50-50. So you're going to get orthopedic remodeling and change. And as you referenced with the podcast episode I had an earlier podcast going into that, I can put the links up in today's show as well. So people want to check that out, what you were speaking about. But I talk a lot about that and in my courses as well of just the concept of, we need to think about this differently. You said it so perfectly, is that sometimes knowledge is the biggest offender of our imagination. And I think we get so bogged down by how much we know. And I almost think that's why, and I've theorized this before, but what you said makes it make even more sense to me, is that might be why the pediatric dentists and the general practitioners are much more open to this, because I mean, now that I do this and this is all out on the web and free to everybody, I get comments and people reach out to me from all parts of our profession. And I really find that there are pockets of orthodontists, the guys like Bruce Ollins, who's just amazing, and a contemporary of yours who's still pushing that envelope and looking to be better every day. But a lot of orthodontists don't want to hear a lot of what I'm talking about and saying, but a lot of the GPs and pediatric dentists are like, absolutely, or I've already been doing this, or I knew this was a thing. Thank you for kind of bringing it to light a little bit more. And I almost think the orthodontists know too much. We've been almost kind of a little bit more made a little more myopic by our extra education. And then you said, and use the term kind of loosely. In my word I'm using here is indoctrination. We become a little bit indoctrinated by the philosophy of the faculty that are teaching us for 3 years. And if they're teaching us an older philosophy that they believe in, and many of them haven't, and this isn't a criticism, it's just a fact, many of them haven't been in private practice. They haven't really been in a position like you have been or I've been, where, I was in my own practice, me and the only one there, and I just had to try to start to figure stuff out. And when you do that with the foundation and the fundamentals that we learn in science and bone biology and biomechanics and all of the things we understand, that's to me what it's all about. It's like, take what you know and then try things responsibly, obviously, and then push that envelope. And that's when I started to figure out, oh my gosh, I never learned this, but this is a totally transformational approach to how to treat these patients by going in younger, putting braces and wires on them. And another interesting thing, and I'd like to hear your thoughts too, and the data are there's a lot of literature on this, but one thing is the psychosocial impact of making these kids look good younger.
I know.
It's tremendous. And I didn't know that would happen, but all of a sudden I started having parents say to me, Dr. Mike, like, they're a different kid. They used to not want to go to school, and now they love going to school. And they just told me that, that maybe 6 months or a year into treatment, or almost at the end of treatment, phase 1, they said, parent would say, they just told me that they were really getting, this one kid was teasing them all the time and calling them names because of their teeth and SpongeBob or whatever the case was. And they don't have this problem anymore. And I wondered why they hated school. He hated school, but now he loves it. Why is our profession not saying, again, the literature's there to support, it's not a myth or a theory that can't be proven, that psychosocial benefits of orthodontic treatment, even in younger kids, are real and tangible. Like, why are we like, nope, got to keep them this way till they're teenage 12 and I don't get it.
Well, I get it. And it's like class 2s. Now, using functional appliances, Pancherez and Terry Dischinger, they swore that you never, ever want to start that in the mixed dentition, class 2 correction, because it's unstable. So, and I almost everybody I'm trying to teach mixed dentition class 2 correction, they don't do it. And it's just because that's what they were afraid of. And it's the same way. It's almost an ego thing too, that they haven't been taught early treatment for most orthodontists. And that way they don't know how to go back and learn it. Their ego gets in the way. Yeah. But, the key with class 2 treatment in a mixed dentition with a functional appliance, and I use a Herbst appliance, but Mara, whatever you use. The main thing you have to do is you have to follow it up with a nighttime functional appliance until they get all the permanent teeth. So then they've got all of this time now. So my cases in the mixed dentition, not only does it help them psychologically, but it looks better when I'm finished, because I've got that several years of protrusive lower jaw, and I've got ways in which I don't move the upper anterior teeth back, and I don't procline the lower anteriors, and it's taken a long time to develop that, but that's my most beautiful cases. I mean, I could show you some today if we have time.
But we would absolutely. Let's do that as we get a little further in. Please, we'll set aside some time to show some of those, because I think seeing is believing for a lot of people, and I think just I always say, like, it's kind of play on words, because a lot of this is expansion too, but expand your reality. I really just try to expand people's reality with this stuff. And I'm not going to sit here and tell an orthodontist the way they have to practice. At the same time, my goal is to show them that there's so much more out there. And that's one of the things I love about teaching the residents is they haven't had enough time to get too much knowledge to learn it the wrong way. They're seeing all these different approaches, and I can say to them, hey, look, and I've got the cases of 20 years of clinical practice to show, hey, look, this is what you can do. And I know it's maybe not conventional in what the profession is teaching in general. And you bring up a really great point too about the fact that they're not doing early treatment. And I think most people, I have a lot of parents actually and patients that listen to the show and reach out to me about it. And one thing I've heard from a few people is just utter shock that most orthodontists graduate from a residency treating fewer than 5 patients under the age of 10. And
Right.
and they are
Right.
literally, and they're like, the people, they say to me, they're like, but we have the AAO, we've seen at the AAO where patients are supposed to go to the orthodontist by the age of 7. Like, why are you guys not treating more of them? And again, we could go on forever as to some of the reasons why, but it's a fact. And while it's not every program, it's the majority of them. And so that's a great point. They come out, they've never learned it. They've actually learned quite the opposite, that it doesn't really work. A lot of the studies that were done on it, sadly, Little and Rydell and some of them that were doing some of these studies, if you look at what they did, the way they were doing it, not all early treatment is the same. It's not all, it's not apples to apples. And you can, really go in there and try for 2 years to try to redirect things and have a complete mess on your hands if you don't know what you're doing, or go in and do things that are mildly effective. And in the end, you can say, oh, there was no net change or benefit versus controls. But a lot of those studies, if you look at them, and it's been refuted by some counter studies that will say, look, they had, inconsistent retention protocols, and some had no retention, and the actual patient age was very variable, and the way the technique of the provider was very variable. So we took some of these studies that really bashed early treatment, and we just universally applied it across all methods of early treatment. And then we stopped teaching residents, if we ever even started, I'm not sure, how to do it. And I guess then it kind of makes sense why they come out and have no desire or really passion for early treatment.
Well, I go back, and I used to see transfer cases that had early treatment. I think they were just trying to make more money and start early.
Yep.
But they had no progress. They had no progress. It was horrible.
Yep.
And so that didn't help things in our profession either, because they didn't know how to do and what to do and be concise about it and make it easier, so that phase 2 was a walk in the park.
Slam dunk.
And
yep.
Yeah.
I think that's a great point. And that's how you've done a good phase 1, when phase 2 is either not needed or is super easy.
Right. Right on.
Yep.
You got it.
So kind of taking that to the next level of what your evolution, as you were referencing, you got really into, you're doing a lot of early treatment. You started evolving in the 80s, you were saying, into really focusing more on smile arc and a lot of the aesthetic side of things. And I want to start by talking about the Disclusion and bite ramps and bite turbos. And they were a complete game changer for me. Even in phase 1. I mean, I think that's one of the things once I started building bite ramps and disoccluding these arches, and then you watch what an 014 Nitai or a light 2020 Nitai can do when you have disoccluded these arches. It's amazing what can happen. And taking that into the sort of comprehensive adolescent or even adult cases, I don't think we think enough about just how much the occlusion can resist movement and tooth movement and arch development and all of those things. And I also feel with the TMJ and a potential of a discrepancy in CR and CO, and that I would just watch as I would disocclude these patients. And again, back to the residency, they don't really learn much about bite turbos or bite ram. I kind of call my posterior bite ramps and my anterior turbos. It's a little thing I just nomenclature my own practice, but I kind of uniformly, I guess, call them bite turbos to open the bite, whether they're posterior or anterior. But they don't really learn a lot about it. And I'm teaching them, if you can separate and disocclude this patient early and then use some light elastics, which again, they are still being taught. You don't ever put elastics on at a bonding appointment. And I'm like, no, you and probably 95% of my cases, I would put elastics on at the start. And so, and I know you from following some of your teachings agree with that philosophy. So how did you kind of figure a lot of that out? And then how did you find it changed the way you approached your cases and the results that it could get you?
Well, where I started using disarticulation was back in early 1980s, when Ormco had a beta test on lingual appliances.
Okay.
First of all, Ricketts said, never, ever. I went to Ricketts in 1974. And that was the best thing I ever did. But he said, never put a posterior or anterior removable bite plate, because that'll cause lack of posterior support and some joint problems. And so I never did. But then when I had this beta test, I strapped up about 30 cases, linguals. And what I saw was just the opposite. If they had any TMJ symptoms, they went away.
Yeah. Yep. It's like a splint essentially at that point.
Right. Because they were connected to the teeth, and the proprioception, I wouldn't let them clench as hard. And, but anyway, what I noticed is that for the first time when I had a deep bite, I never had to intrude upper anteriors.
Yeah. Yep.
Because I was open in the back and the back teeth were erupting.
Yep.
And so it was just the light went on.
Yep.
And so that's when I started using bite turbos on every case. Of course, I was using them on the posterior to intrude the posterior open bites, or the anterior open bites, the posterior teeth. But it's just amazing what happens. And of course, it speeds up the case. The case looks more beautiful. You know, as far as the smile is concerned, the prosthodontists started talking about the smile arc and incisal display. I read an article when I was in dental school. It was written in 1958 by prosthodontists. And, you know, it's what orthodontists have gone to now with the multidisciplinary. They'll straighten the teeth, and then they go to the prosthodontist to put glass on 28 teeth, cost them $80,000-$90,000. And anyway, that just became an obsession with me, is how I could create a smile that was better. And so then I started playing with bracket position and bite buttons. And I always put bite buttons and early elastics on every case, even if it's a touch-up case. Because you can't widen the arches unless you disarticulate.
It's so true.
So anyway, that's just been my passion. And bite buttons and immediate elastics are my threshold. But when I went to passive self-ligation, then I could use very light elastics, 2-ounce rubber bands. And I get beautiful movement if I'm disarticulated.
Like 3/16, 2-ounce 3/16.
Yeah. But not only do orthodontists not want to start with elastics, but then they wait, and then they start with heavier rubber bands, which kills the patient.
Oh my gosh, I say that exactly. Yeah.
So anyway, you and I maybe are brothers from a separate mother. I don't know.
Seriously, if the residents, I know some of them do listen to the show, and they're probably laughing hearing you say that, because I'll literally say to them, like, when they ask, obviously I don't just say, just use the elastics. I explain why we're going to use them early, exactly similar to what you were saying. And I say, think about it. The traditional approach is you don't disocclude these patients. You fight the occlusion to try to straighten these teeth for a year. And then you get a year in and you realize you're on class 2. And you might have not even started that class 2, but as you've worked the compensations out of the bite, leveled the lower arch, you're on class 2. Teeth are now looking pretty straight. Arches aren't quite developed enough. And now you tell this kid who's been in treatment a year that they've got to wear a 6-ounce elastic, a 1/4-inch 6-ounce elastic. And no wonder compliance is terrible, because it hurts. It's uncomfortable. They're at the point where their braces don't really bother them. And especially if you're using self-ligation and light forces and light wires, my patients had minimal discomfort. So you go throw a heavy elastic at these kids a year into treatment, compliance is going to be minimal. Whereas I found too, when you give them a light elastic, like you were saying, 2.5 ounce, 3/16 inch from the start, you disocclude them, you see them back in 8 weeks, 10 weeks, whatever people want to do. It's fun to watch the residents see them. They're like, whoa, how did that just happen in 2 months? I'm like, because of all the things we've been talking about. And the patients are so compliant. It's not 100% compliance, but it is up there in terms of the compliance. Yeah, because it's light, it's easy, and everything's new. And I always tell them, if you wear them well in the beginning, the first couple of visits, you give me full-time elastic wear, there's a good chance you won't need them again, or maybe just at the end to kind of make things perfect. And I was usually true to my word on that. If they warm well in the beginning, I rarely need, and every now there's outliers, that are just, you need more extreme things. But I'm talking about, 80, 90% of your cases that you could achieve that.
Ron Roth used an 8-ounce rubber band.
8 ounce intraoral 8 ounce.
Yeah, all of his patients eventually ended up Navy SEALs.
Yeah,
I'm sure.
seriously, man. And was that like a
Talk
class
about a
2
headache.
vector? He'd use them in like a class 2 vector.
Class 2 or class 3.
Yeah.
Yeah,
Wow.
it's unbelievable. But
Yeah.
I totally agree with you. So we came to the same conclusion for sure. I just, my treatments now with the control we have with the square wire technique and the passive self-ligation and the light wires and the light elastics, the disarticulation. I mean, I'm finishing anywhere from 9 to 13 months
Oh,
on a standard case.
that's amazing.
Yeah.
That's
So,
absolutely amazing. Yeah.
yeah. And on a mixed dentition, I don't want to go over 9 months
Yeah.
unless it's a class 2.
Yeah.
A skeletal class 2, then it's a different story. But class 3 is open bites, crowding. We want to get in and get it done
What are you
because I've
typically
got,
retaining? I know in the case of an anterior posterior, you're having them wear more of a functional positioner, but how, just kind of your standard arch wire expansion, young, how are you typically retaining them?
I just use clear retainers.
Same.
And then
Yep.
I cut out as the primary teeth yeah.
Same. And people listening to this, like, to me, it's like, yep, 100% people listening to this are probably like, wait, what? There's no way it's stable. No, it is so stable that it's absolutely, I get it. If I have it, I have the receipts. If you want to go, I have a lot on YouTube. I'll put some links on this just so people can see my results and years out stability. And I had some articles I published in Orthotown to show it as well that I can link to, but it's so
Great.
different. And I used to, when I started really with heavy upper lower turnkey expanders and lower, and just to be clear for everyone, because I'll hear this a lot of times, we're not talking about expanding the mandible. It's the mandibular arch and developing the teeth and putting them up over the bone when there's a steep curve of Wilson and constricted arch form. But I would use a sort of a fixed Schwartz, Williams was what it was called, on the lower, and I'd use an RPE turned either rapidly or slowly on the upper in these younger phase 1s. But it was just so much for these kids to tolerate. And then you're putting some brackets on and you could never get the incisal angle correct. It was flat and you didn't get the development in the anterior middle thirds of the arch. And, the poor kids, their speech is a mess. They're not eating well. And so their tongue's having all sorts of ulcerations and fissures in it. So there was all these challenges with the traditional expansion approach. It worked. I mean, I was developing the arches nicely and it overall worked. And at that point, I was retaining them with an upper and lower Hawley. So, I mean, it was a lot between what the kids were going through and what my team and I were going through doing this treatment. I mean, I can almost see why a lot of our colleagues don't want to do it, because it was not the most fun and we're not trained to treat these young kids. And now you're throwing upper and lower expanders on a 7-year-old kid. And so I think those are, again, some of the reasons maybe we don't do a lot of this. But when I transitioned what now is going almost 15 years ago to doing with braces and wires, it was just such an absolute game changer. And the patient tolerance, the parent tolerance, what it did for my clinical efficiency, streamlining that system. And it takes time to learn. And one of the reasons I'm trying to teach it more, as I know you feel the same way, is so others can kind of learn from my mistakes that I made and figuring this out and using my imagination to try new things. But once I got it down, I mean, it just is such a wonderful process for all parties. And then the retention, as you stated, clear upper lower retainer, cut out as the teeth come in, see them every 6 months for a growth retention check. It was just, I don't know. It almost seems too simple to be true, but when you do it and it's just, there's nothing like it.
Oh, back in the late 70s, I started a study club, and I still have a study club, but it was mainly about aesthetics and how we could improve aesthetics. And I started using Crozats on the early treatment.
Sure. Yep.
Yeah. And actually it worked pretty well, but once you see how easy it is to do the fixed, and particularly when we So anyway,
Yeah, show patients. Say
it's
you want show them a crow's at. So like, you want this one or you want this one with some braces?
yeah, yeah. I haven't used a rapid paddle expander since 1979.
Wow.
Now my son is getting into using some CAD assisted expanders,
Yep.
and I can on adults,
Yep.
but anyway, the soft expansion, uh, I just love it. And
Yeah.
when I used to have the 022 by 028 appliance, I would have to put some uh, buckle root torque and
Hmm.
buckle segments. Otherwise, you get flaring of the buckle segments,
Yep. Yep.
particularly for molars.
Yep.
So, but now I don't have to do that with the 21. Yeah.
Yeah. No, that's right. So actually on that, let's talk a little bit more about that 21. And if you want, as we kind of go through
Oh,
this, let me know a good time to jump in and show some cases if you don't mind, because I'd love to just
let's
help
do
people
that.
see what this can do. And for those of you on audio, just when we start showing some cases, I'll reference it so you can hop on at that point on the YouTube channel, and that'll be obviously be links to this in the audio versions of the show as well if you listen to us on Apple or Spotify. But I think it'd be really cool to see this happen, because you and I can sit here and talk about it, but what really matters is what this looks like in the end. So if you don't mind, yeah, maybe let's just share here and you can kind of have at it. You control and pick what you want to show, and I'll enjoy learning as well as you kind of go through it. And I'll just kind of ask you some questions and things as
Okay.
we go.
This is just to show how I make extra space for the canines,
Mm-hmm.
upper and lower, so
So
that
phase one patient, early mixed
then,
dentition, early to mid mixed dentition. Yep.
yeah. So then I just hold those anterior teeth together and retainer with a clear retainer,
Yep.
and I'm getting those cuspids in all the time. Uh, when I started dealing with the smile, I wanted to get a smile arc for
Mm-hmm.
sure, but the
Mm-hmm.
smile arc is no good unless you have full incisal display
Mm-hmm.
and hopefully a little bit of gingival display. So it just, this is not a Invisalign treatment.
Mm-hmm.
You know, if I can start with fixed and I can finish with some aligners, that's fine. But
That's
when you
beautiful.
take, isn't that beautiful?
Oh, that's
Uh,
so gorgeous.
Here's a couple that she was treated orthodontically, and you
Mm-hmm.
can see the flat smile, and then
Flat
by the
caved in
time
arches. Yep. Yep.
yeah, and he was in these fixed appliances for 5 years, and then but I changed his personality when I
Yeah.
was able to create that smile.
You can see it in both their
Uh,
faces. You can see in both of their
yeah,
faces.
you can see it.
They
It's
literally
amazing.
look completely different. Yep.
Yeah, and here she worked for me, and I
Wow.
tried to get her to. She couldn't show more than 40% of her upper centrals,
Yep.
and I finally talked her into treating it, and it just made a difference. And of course, then she got married. You know why? Here's one that Nemeth did over in Portugal, but
Wow.
this lady had
Unreal.
four
And that's no
bisex,
restorative treatment. I mean,
no
reshaping,
restorative,
no
no
actual.
restorative.
Wow.
Yeah, but she had four bisex out,
Mm-hmm.
but she had no incisal display. But
Yeah.
once, I mean, she still has I saw this patient over in the Met's office, but it's just, you know, orthodontics is in the dark ages in so many
Ugh.
parts of the world.
And
There's
her
Nemeth.
face too. I mean, look at the change in her eyes and her. I mean, her smile lights up a room now.
Exactly. So anyway, the the
Wow.
the treatment planning is different now, and how can I make this arches wider, and how
Mm.
can I get the teeth upright? Nobody likes proclined anterior teeth,
Right.
and I see so much of that, and then to have this smile arc and the vertical incisal display. This was done by Wasim over in Algeria. But just taking these five things, and that's what I've tried to develop the best way I can. And number one is wow aesthetics, both facially and smile, and still have a wonderful functional occlusion and
Mm-hmm.
be efficient. I mean, get down there under 15 months and have less force, and of course serve the people. Oh, this is fun. I treated this lady when she was 13, and then she brought her kids into me a couple of years ago, and I said, well, I started showing her pictures of what we're doing with the smile, and so I retreated her, and it's just amazing what we can do now. And so I'm trying to make people aware of that. And of course, we do a lot of proportional adjusting with the laser.
Laser, yeah. I love that. Yeah. One of the things I hear about a lot, and I just kind of to the later stages of my clinical career, we're starting to implement some of these techniques. I wish I had done it sooner in certain cases, but a lot of people say that there's no way to do what you're doing and kind of extruding those upper anterior teeth, getting that smile arc better, that the bite is going to be too deep, or you're going to leave them with, it's going to cause all the things I'm sure you've heard, but because that's a lot of things the naysayers say. What is your answer to that?
I had to figure it out. I mean, my finished occlusion looks as good as anybody's. And so it's a matter of learning the biomechanics of how to do it.
Yep.
And knowing that I'm not going to, on a person that has a good upper lip and a nasolabial angle, I'm not going to take those anterior teeth back, no matter what.
Yep.
And so many practitioners have gone to a very high percentage of aligners in their treatment because they can treat the cases sometimes better with the aligners than they could with fixed, but they just don't know what you can do with fixed. So unless they have a good incisal display, I'm not going to put aligners in.
And so this is more challenging to do this because of the challenges extruding anterior teeth with plastic. Is that what you're saying? It's logistically harder to do.
Yeah, unless you want to use 500 aligners, it's going to be very difficult for them to reproduce that. Yeah.
Yep. And the slide you had just before that saying that most of us are still focusing on being tooth straighteners. It's so true. And that is something I talk about. When I feel like I'm almost preaching on it all the time, because it's just, I feel if we don't, as orthodontists, realize that we need to be better than just tooth straighteners. I mean, the days of putting plaster on models on the table and looking at how they look have to be gone. Like it's fine. I'm not, it was a stage and fine. And it's an evolution in our profession, just like in anything in life. We shouldn't be ashamed of it. We don't need to hide from it or run from it, but we do need to look at it now and for what it is, which is an antiquated way to approach treating our patients.
Yeah. Well, that's why I created the master's course. And I just wanted to throw this in. I'm starting another one next March.
For people to register, I can put it in the show notes for people to register.
That'd be great. Yeah. JoniAbel@me.com.
Okay.
Well, let me show you here. Can you see that?
Yeah, that's a pretty good group.
Yeah, I had a Pitts Masters reunion back in November and from all over the world. And
that's so cool.
These are the teachers that were there, and most of them, a few of them took 45 minutes, but most of them took 15 minutes. And I said, I want a TED Talk, and I want you just to show the cases and show exactly how you got there. And it was so emotional and so wonderful. I mean, these people all, of course, took the masters, and they're great. But anyway, these are courses coming up. You asked me how people could learn more, but we're doing a Denver one day in August, and in Newport Beach we're doing another one on September 27th, and orthopreneurs. Glenn Krieger was nice enough to suggest we do it down at his place September 6th.
Nice.
Dallas. And then I've got Wasim Bosid coming over from Algeria to speak to PCSO in Palm Desert in November.
Oh, cool.
And I think he speaks on the 15th. So, and then I'm going to do, this is that course on September 22nd down in Newport Beach. So anyway, I'm just excited about more patients getting treated this way with not only Airway, but its appearance. And so Ricketts was my man. he taught me so much, and he wasn't well liked because of his gruff demeanor, and he wanted to bait everybody. But
Yeah.
Anyway, when I was treating with Damon, it was very hard to control, both rotational and torque wise. So I started treating with a square wire. Of course, I had more in and out bends, but I was able to control the torque a lot more, and the force was a lot easier. So that's when I decided I wanted a square wire appliance. And we first went to this PITS 21, but of course there was problems with the slide, and now this is a more streamlined version we just came. But it's a big deal here, because when you metal injection mold a bracket slot, it will not come out square. It's always rounded. In H4, I took the labial lingual bracket depth and I changed it from 028 to 026.
Okay.
And it was very good, but I had a lot more control, but I had to round the edges more in the wires because of this. And that's the problem. A lot of people now are taking their passive brackets and shortening the labial lingual slot depth, but they have to round the edges. And when you round the edges of the wire, what happens is you lose torque control. So this is, we cleared that by making special little slots on the corners, so that now we have full torque control and we don't have to round the edges. And so we're torquing in a third wire very, very nicely. On the right there is what I was using, that the universal arch form that has been known as the Damon arch form. But I had to wait until I got into the TMA or steel wire before I could start widening. And so it was taking me longer. Now I went to this broad arch on the left there. And but whenever I put that in, I always widen it out a little bit. So so anyway, that's a little look at some of the things. Oh, class twos. We have a little time for class twos.
Yeah, go ahead, please.
When I went to University of Washington, functional appliances didn't work. All they did is move teeth. And so all I had to do with class twos was use a headgear or take out upper buys or surgery.
Which is still commonly what's taught today, those three options.
Yeah, right. So anyway, what happened is a year and a half into my practice, I had a young lady come in with a son. The son was 7 years old, and he had condylar agenesis on the right condyle. There was no condyle. And he had no chin. I mean, literally, I don't know how he breathed. So I just read an article by Eagle Harvold, Dr. Harvold, who was head of the University of California. He was head of craniofacial. And so
his monkey studies are huge in the area of the impact of nasal breathing, obstruction of nasal breathing on craniofacial growth and development.
Yeah. So anyway, I got an appointment for this little, not this one, but this little guy that had no condyle and actually very little on the left. And so we went down, and Harvold made him this asymmetric activator that way open on the one side and shifted his mandible over and opened. He was open 13 millimeters in the anterior region. Anyway, long story short, in 3 years, the condylar process grew right up into the fossa. He had a really good profile, and I couldn't believe it. And so apparently functional appliances worked in San Francisco. Where they
geographic sensitivity there.
So I started studying that, but it's really tricky how you use functional appliances and how you maintain the anterior teeth forward on this type of a case. And get the chin balanced out. So anyway, I took up the study, and that's what I worked on for many years. And here was a little child of a college classmate. And, she had a beautiful upper lip, but she was really chin retrusive. And so I actually, this was my first herps. It was a removable herps because this was 1977 before Terry Gissinger brought Pancher's fixed herps back.
Yep.
And so I learned how to overtreat and start finishing with some light class 3 elastics and hold in over treatment. And so we were able to take cases like this and make them beautiful. Where I mean, you can see there's no upper orthopedics there, and there's no lower proclination of the lower incisor either.
Yep.
So that was my study also. William Arnett has a nice cephalometric evaluation for his surgical cases. And so he draws a vertical perpendicular to Frankfurt through subnasally, and he likes the upper lip to be about 4 millimeters in front of that, and 2 millimeters on the lower lip, and then -2 to -4 on the chin. I try to get orthodontists to see, as they're treating class 2s, that they're not just treating the upper back to the lower, but it's how you manage to keep the upper where you want it and get the lower where you want it. But you have to way over treat, hold it for 4 months. That study's been done at West Virginia. This case, this drives me crazy.
Yeah. Yep. Bringing that upper back. Yep.
Bringing the upper back. I mean, here he extracted upper first bicuspids and had her wearing a headgear.
Yep. For anchorage to retract everything. Yep.
Gosh sakes, drive me crazy. So, but anyway, most of these cases I treat are in mixed dentition. And so I overtreat and then put her into a functional appliance at night. And then when you get permanent teeth, but you'd never know that this young lady was a severe class 2. Now she's missing a lower incisor congenitally, but look at that face. It's just amazing.
And that ties into what we were saying before about the psychosocial impact of just these cases you're showing on these kiddos.
Yeah.
This is life-changing stuff for them. And again, I don't mean to keep repeating it, but this is where I say to our orthodontic colleagues, why would you not want to do this and use your imagination to, I look at it as take your knowledge and then use your imagination to combine them to create something really, really great. And to look at people who do this and say, and even if you don't want to do it, right? Because let's just say for something like, I just won't do this. But it's interesting how many people really don't want any of us to do this. And they're like, you can't do that. You can show cases all day.
Oh, I know.
Show me the exact study where you had that. And it's like, you could wait all you want for a study. The end of that study is a kid who you just changed their life. And we know that if you retract and you get more retrusive, you impinge upon the airway, you impinge upon tongue space, you have greater incidence of sleep apnea down the road. And people will say it's a correlation, not causation. Well, the fact remains is when you look at adult patients who have more severe sleep apnea, they have narrower arches, less space for their tongue, protruded profiles, higher vaulted palates, I mean, across the board. So if you can do things young to minimize the risk of all those variables that we know exist in the majority of patients in sleep apnea, obstructive sleep apnea is very multifactorial. I understand that, and we go beyond the scope of our conversation today, but we do know that there are certain craniofacial anatomical consistencies in a large number of patients who suffer with sleep apnea, sleep disordered breathing, et cetera. If we could address those young, isn't it incumbent upon us to do so? And why are we fighting to not? I just don't get it.
Yeah. Well, that's why I appreciate so much what you've done and your clinical research and showing what you've shown, because I've spent more of my time on full dentition because that's what most people do. And so I'm trying to get them to see the aesthetics, the occlusion, and efficiency, but we all need to spend more time on early treatment. And that's always been my special area but I haven't taught it as much until I really saw your presentation. And so I really appreciate what you've done, Mike.
Well, thank you
And
very much.
that's one question you've always said is, how can we get this out to the profession? But it's just like this. We just need to write about it and talk about it and get to as many programs as we can, and get some instructors in there that are Navy SEALs like you, that you can get in there and get it taught. That's really special.
Appreciate that very much. And as I said, it's fun when you watch the residents respond to this and see this and are receptive to it and they get it. I mean, it makes sense. It makes a lot of sense. And when you start showing it to them and to the public, and that's what we have to keep doing. So I vow to keep fighting that fight. So I will not stop.
Me too. Me too. And you've stimulated me more. You've got more years than I do, though, and that'll help. This case was, can you see this case?
Yeah. Yep. It popped up. Yep.
Yeah, this was at UOP, and she was treatment plan for 4x extraction as a bimaxillary protrusion. And of course, what I saw was she has a retrusive chin.
Yep.
And you can see her lower incisors are proclined, and she's got that retrusive chin. Her upper lip is a little forward, which is always good when you're using a herpes appliance. But I wanted to do it non-extraction, so I worked with this Jamson Wu as the student's name. He's a great orthodontist down in Sacramento now. But you see, she's not that crowded.
No.
And she's not that class 2 dentally. But she's got the retrusive chin. So my treatment plan was to herpes appliance and way over treat it and hold it. And that's what we did. And Jamson, he used this flip lock herpes. In fact, I've gone back to the flip lock. I can't think of her name, but she took it over and she finished it beautifully. But you can see in that lower right buccal, we've got way class 2. The upper cuspid is biting distal to the lower first bi. And so she used a short class 3 elastics, and we've got some spacing there, which is good. Look at that finish.
Beautiful.
That's impossible. Most people would think that's a setup.
Yeah.
It's just, so it's just that imagination. And trying to do what you think you can do, and being able to evaluate it afterwards. And that's just special. But anyway, she was in the mixed dentition when the treatment started. And
it's so much fun to have the impact that I had on the younger kiddos. I mean, I always say I love straightening teeth. I love giving people beautiful smiles. You clearly, with what you were showing, you have a passion for that and are amazing at it. There's something really neat and unique, though, about taking these younger kids. They're so moldable and pliable, and they're easy to treat. Once you have to have this certain behavior management techniques. And again, unfortunately, we don't learn a lot of that. I think that's why a lot of our pediatric colleagues are more open to early treatment than we are, because they learn how to treat, they know how to treat these young kids and do a lot harder things on them than ortho. So they're very comfortable with it. And then we're not comfortable with it. So we shy away from it. When you start doing it and you know how to do it, they're some of the most fun, compliant, easy patients to treat. It's like, especially when you do have some that you improve the airway, if that's their issue, and whether that's by working with one of your medical colleagues that you detect something and refer them, and then combining it with your treatment, then the aesthetic side, and you just watch these kids in such a short period of time transform. And then you hear the stories of the patients and their parents, and oftentimes parents in tears, talking about what you did for their child. And not that I never had the parent of like a 13, 14-year-old in tears over the smile, but it would be an isolated case. They're kind of happy the kid's done. They don't have to get after them for, brushing their braces the same way and all that. Whereas the younger kids, the parents are like, you don't understand, Dr. Mike. Like, you don't understand what you have done for my child. You don't realize the changes you've made in my child's life, in my family's life. And that's really, again, what burns that fire in me, or what lights that flame, and why that fire in me burns, is because I saw it happen in my practice time and time again. And then I saw my colleagues, whether they were in my area or even others, when I would go teach and lecture, who would just totally oppose what I was doing. And that also motivated me to go teach it on a bigger scale, because I knew what I was doing for these young kids. And it saddened me that our profession, our colleagues aren't doing that. And I think that I have a role to help them learn how to do that.
You're good. You're fulfilling that role. And I really appreciate it, Mike. You've stimulated me to start teaching more in mixed dentition, and I hope we can get a lot more interest going here in the next few years, because like I said, it's not for the profession per se, it's for the patients.
Yeah.
And it's just such a beautiful thing. I got patients coming back now as orthodontists to Reno that I treated in the mixed dentition.
Wow.
Yeah.
So hopefully, as we get more of those that know the benefit of it and understand it, there's a lot of work to be done. And I really want to thank you, and just again, for all you've done to be so passionate about it, at the number of years you've put in, over 50 years in this profession. It's just so admirable, and to still have that fire. Like you said, I'm at my age, like I've got a good part of my career left here, and I'm starting the second half of my career, so to speak, and in this new arena of teaching in a full-time capacity. But for you to have this much passion about it, and the number of lives you've changed with your treatment, but through teaching so many people, it's just so awesome. And I feel blessed to now get to know you and have a relationship with you. And I want to continue to work together on this and collaborate and stay in touch, and if there's anything I can do for you to help you in your journey on this, by all means, I'm more than happy in any way I can.
Thank you, Mike. I'm in the fourth quarter, but I'm hoping for some overtime. And I'm going to be down in Pompano at the end of this month for a couple of months, and so maybe I can hook up with you when you're down in Fort Lauderdale.
Let's do it. Yes, let's absolutely
get to see you personally.
Yeah, no, that would be a pleasure to be able to meet up personally, and yeah, I'm over there, like I said, a good couple times a month, and 2-3 times a month at least. So I would absolutely love that. So one last question. Speaking of kind of the profession, what do you want your legacy to be in this profession?
I want it to be where I want to have a paradigm shift in orthodontics to where they focus on what the patient needs and wants, and make the aesthetics and the efficiency so wonderful. And of course, take into consideration the health and the airway and what it does psychologically when you rack those lips back. That's one thing. In 1983, I forget his name, but anyway, this orthodontist who is a Tweed lookalike, he's over in Provo, Utah, and he wrote an article in 1983 as he was getting ready to retire. His son was taking over his practice, and he noticed that on the brachy and the mesofacial cases, when you extract bicuspids, even second bis, but he said when you finish, the lips are thicker than when you started. When you do a non-extraction, the lips go to the same exact measurement as they started with. But what happens is over the next 3+ years, the lips thin out, and so they get more and more concave, and it's disastrous to their profile and their self-esteem.
And the nose and the chin continue to grow.
Exactly. And so, I don't know that maybe it's not my legacy, but maybe it can be yours, that you make such a difference in orthodontics. And I've got a lot of master's people out there now that are turning out such beautiful work, and they're getting to be good teachers, and their finishes are so wonderful. So maybe that's the legacy, is that master's and what we've started to, that little mushroom cloud, and hope it grows. Yeah.
Absolutely. Dr. Tom Pitts, Thank you so much. You have a profound legacy that you have left and will continue to leave. And we are all owe you a bit of debt of gratitude for all you've done. And sometimes I know it won't be recognized right away as you're pushing that envelope and on the cusp of, no pun intended, on the cusp of these big changes and everything you've done. But in time, it's going to be recognized that people such as yourself who really save this profession and are able to change so many lives. So thanks so much for giving us this time, give the Doc Podcast, the audience this time. I really, truly, truly appreciate it.
Thanks, Mike, for all you do.
Thank you.
Great honor to be with you today.
My pleasure. Honor's mine. All right. Take care.
Okay. Bye-bye.
Bye. Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening. And always remember, you have been blessed with the ability to do amazing things.